a obstructive disease, upper respiratory tract obstructive disease, we may not be able to get the oxygen into the lungs by giving nasal oxygen or through nasal prongs or flow by oxygen. We necessarily we have to go for tracheostomy, or we have to at least go for intubation and give oxygen through the amp bag minimum. So we should know how to give oxygen therapy, how to make small procedures to effectively give oxygen where it is required. For example, if it is, a problem is there in the thoracic part of the trachea, then there's no point in giving nasal oxygen. We have to give even tracheostomy will not help. You have to go deeper than that and deliver oxygen. So such of those techniques we should learn while treating respiratory tract diseases. Next is intubation. Intubation is another skill which every veterinarian should learn, which is easier. Both on dorsal and ventral recumbency you should be able to intubate, because always the patients, or respiratory tract disease patients, are presented in a very bad critical condition, and the time given to us to save the animal is very minimal. So a successful intubation means you have the dog's life in your hands, because once you intubate, there are so many medicines which you can throw into the tube, intubated tube, directly into the lungs, which can save the patient. That's called NAVAL. N stands for naloxone, A stands for atropine, L stands for lignocaine. So atropine, lignocaine, all these drugs can be directly put into the intubated thing, and you can save the life of a dog. So intubation is a skill which we should learn. Then thoracocentesis. See, thoracocentesis is always a procedure which is very easy. You need not be thinking that it is very difficult. So it is a must procedure we should learn, because if you don't do thoracocentesis, we can lose the pet. So you should definitely do. And once you see a paradoxical chest movement and it is because of fluid in the chest cavity, you should be able to do a simple procedure called thoracocentesis and remove the fluid and make the animal breathe. Next is nebulization. So nebulizers are a wonderful means of getting aerosolized particles of drugs into the lungs, which is easier to achieve concentration which are required in an emergency basis. Okay, you can have steroids, you can have bronchodilators, you can have mucolytic agents. All these things, you can nebulize and find immediate response to the treatment from the pet. Analgesics. Another mainstay of respiratory tract disease is analgesics. You may be wondering what analgesics has to do with respiratory tract diseases. When all these patients are presented with severe respiratory distress, the intercostal muscles work so much, they all have severe pain. Once there is pain, the pain mediators, start producing inflammatory mediators like interleukin 6 and interleukin 3. All those things are produced, which in turn affects the heart rate. So there is going to be an increase in heart rate. It's a vicious circle. So the moment that the pet comes with severe respiratory distress, if you are able to use analgesics and reduce the pain, the response to therapy will be much more. Of course, antibiotics. Again, when you're using antibiotics, of late I see veterinarians start using all high-end antibiotics. So we have a responsibility towards a human population, wherein indiscriminate use of antibiotics will lead on to developing resistant pathological organisms. And therefore, we should definitely use antibiotics. There's no doubt about it. But we should have indications for using antibiotics. So it should not respond to your normal treatment. There should be a fever. There should be a leukocytosis. If all these things are there, then there is every use for the antibiotics. Not for all the cases of respiratory tract diseases, antibiotics should be used, indiscriminately used. And to start with, we can always go for a simple antibiotics like ampicillin or potentiated amoxicillin or doxycycline. Afterwards, if it is not responding, then we can go for higher antibiotics, cephalosporins and things like that. So antibiotics are a must for respiratory tract diseases. and it should be used very cautiously. Bronchodilators. So whenever there is a respiratory tract disease, so the bronchioles get constricted and the bronchial spasms see to that the air doesn't enter the alveoli. So unless you dilate them, the oxygen cannot enter into the alveoli. So you use bronchodilators. Cough suppressants. These cough are, making the dog's life very worst, and it increases their, anxiety, and the effort to respiration is much more when the cough is not suppressed, and therefore it goes into a vicious circle. So cough suppressants are always a must. There are a lot of allopathic drugs, a lot of Ayurvedic drugs which go into reducing the cough in pet animals. Anti-inflammatories. Anti-inflammatories, because any disease, there's going to be inflammation of the system. So it can be inflammation of the upper respiratory tract or lower respiratory tract, or the bronchioles or the mediastinum. So we need to address this inflammation by using anti-inflammatories, sedatives, so that these pets they're very anxious, because of concentrating on their respiration, and the vicious circle which I told you, which will make them highly anxious, and they make more efforts, and so you have to use sedatives so that they are less, anxious, and they don't go into that vicious cycle mode. The first procedure which we should know is thoracocentesis. So the pleural effusion, okay, that is the cavity between the lungs and the chest is called the pleura, and it has a small amount of fluid which takes care of the movement of the lung and pleura. So if it is going to be excess, then there's going to be what can be absorbed through the lymphatics, then the fluid gets accumulated into the cavity and causes restriction of lung movement, and therefore gaseous exchange will be suffering. So you have different types of effusion. You can have a hemothorax, blood in the thoracic cavity. You can have chyle in the thoracic cavity. You have a purulent material in the thoracic cavity. You can have neoplastic, materials in the effusion in the thoracic cavity. And usually in cardiac problems like right-sided cardiac failure and congestive heart failures, there can be, because of the hydrostatic pressure problem, there can be effusion in the pleural cavity. And pneumothorax. Pneumothorax is air in the cavity usually because of a trauma to the chest cavity or a lung abscess. All those things, air can get accumulated in the chest cavity, making the lung difficult to expand. And until you remove this fluid or air, it is very difficult for the patient to survive. Site is, you can a pet which is brought to the hospital with severe pleural effusion, it's very difficult for them to be on recumbency. So they'll be mostly standing, and you can choose a standing position itself, and you can choose a 7th intercostal space. Okay, left side or right side, both sides you should drain. So you can do the upper 2/3 for air, and if you suspect a fluid, the lower 2/3 you should have punctured. Just have the needle on the rib, 7th or 8th rib, and just walk it cranially towards the face. If you walk it cranially, just slides into the intercostal space, and you will have fluid entering into the the butterfly needle. If you are using the caudal part of the rib, then you will rupture the blood vessels. So you should be very careful. You should walk the needle on the cranial side of the 7th rib so that you'll be not disturbing the blood vessels. Okay, entry in the 90 degrees. As you enter, then once you know you have entered, you can just make the needle parallel to the chest cavity so that it doesn't scar the lungs. To start with, you will not have any problem because there is fluid inside. The fluid will be coming out of the butterfly needle. But once a fluid is emptied, then the expanding lung will come and rub the needle and gets scarified. So you should be very careful. So next thing is you should make the needle parallel to the ribs. Okay. The quantity of fluid which you can relieve. This is again highly questionable. So you should remove only minimal fluid which can which will not interfere with the respiration. because if you remove the whole, effusion, it's a protein-rich fluid that can lead on to loss of protein, and that can reduce the oncotic pressure, and you will have more fluid formation into the thoracic cavity. So the quantity of fluid which you relieve, this one is for diagnostic purpose, another is just enough to cause ease of respiration. These two are very, very important when you are removing the fluid from the chest cavity. So this is a rough, diagram wherein you know how to insert the needle. So you just make a line, and the upper 2/3 you use it for air in the thoracic cavity, and the lower 2/3, that line, you use it as a marker for fluids. And you need not be very much worried about exact place and things like that. Lower 2/3 and upper 2/3 are excellent marks, and just you put a needle. As I told you, the entry should be cranial to the last rib, that is towards the face. Then you will be able to do an excellent thoracocentesis procedure without any problem. The pet doesn't even require sedation, because already it is stressed out. It is not going to interfere. It is a small needle which you are going to put, and it's all the more very safe procedure. This is a three-way stopcock, which is very, very important. Say, supposing you are putting only, you can definitely put a butterfly needle. If you don't have a three-way stopcock, you can put a butterfly needle, because air cannot enter, because fluid is coming from the butterfly needle outside. So air cannot enter. But in case if you don't have fluid in the thoracic cavity, then air can enter and cause pneumothorax. So you can always use a three-way stopcock. The present position is attached directly to the chest cavity. You can see the arrow mark. So you can directly draw the needle, a plunger. You will be able to collect all the fluid, and then you change the direction of the three-way stopcock. You stop the entry of the fluid back into the chest cavity and direct it towards the collection wire. Then you'll be able to, without removing the needle, you'll be able to empty the entire chest cavity outside. This procedure, I'll show you a video. So this is how you keep changing the three-way stopcock. And then you start removing the fluid and draining them outside swim. So this is a paradoxical chest movement. You can see the chest and abdomen go in the opposite direction. Very clear indication it has got a pleural effusion. Put only a butterfly needle. Okay, so this video is only for you to see the paradoxical chest, where the chest and abdomen go in the opposite direction, which is very clearly indicative. This is chylothorax. This is consists of lipids and triglycerides. We will see what is chylothorax in the later coming swim. It's a purely a whitish liquid consisting of lipid and triglycerides. This is a transurethric which is accumulating in the thoracic. So this is due to different problems which we will deal later. So especially can dealing with this biothorax very, very carefully, because this is actually of infectious pneumonitis. Any other problem also, it can be lung abscess, it can be endogenous spread of infection. So all those can cause biothorax. So this is purulent material inside it can be infective or non-infective biothorax. So all those things tests should be done in this material which you have collected. Next is chest tube placement. Chest tube placement is very important. Supposing you have lots and lots of fluids and you think it's going to keep occurring again and again, so you need to put a chest tube so that you can draw from the pleural cavity, fluid can be drawn at regular intervals. You have two methods. One is a threading method, where this, that orange tube, you thread it from the 11th intercostal space, you tunnel and go to the 7th intercostal space and introduce it perpendicularly and suture them. That is the first method. The second one, the trocar. You have the trocar and that plastic outside sheath is there. Again, here also from the 11th intercostal space, you make a small nick on the 11th intercostal space and you tunnel this trocar towards the 7th intercostal space. Once it reaches, remove this, upright this trocar 90 degrees angle perpendicular and just give a firm pressure towards the mediastinum. So the whole tube will go inside and they can remove the trocar and suture the tube to the chest cavity, which will facilitate easy removal of fluid. Again, this will look very difficult, but when you practice it even once, then it will become very easy for you. This is a method. First one is the tube where you, from the 11th intercostal, you start threading with the forceps and reach this 7th intercostal space, and then you enter into the chest cavity. This is second one is the pop-up method, where the trocar is brought to the 90 degrees angle and pushed inside the thoracic cavity, and the whole tube is sutured to the chest cavity so that you can regularly drain the chest fluid. This is usually a matter of a procedure done for when you do a thoracostomy. Otherwise, when you find there is a lot of fibrinous chylous fluid or a pyothorax, then these sort of chest tubes can be placed where you can give a lavage regularly and remove the fluid from the chest cavity. Oxygen supplementation, I told you, whenever you have hypoxemia, you have hypoxemia due to several occasions. Of course, respiratory tract diseases, which is one. So laryngeal obstructions, facial traumas, epistaxis, coagulopathies, nasal mass lesions, all these things, direct flow by oxygen is not helpful. You'll have to, intubate and give them, because all these things, they have a problem in inhalation. The upper respiratory tract problem is there. Either a mass is there, or a blood clot is there, or epistaxis is going to stop from the entry of air into the lungs, or laryngeal obstruction. All this thing can stop the air from reaching the lungs, and therefore all these diseases you will have to give them through a chest tube or a tracheostomy tube. Patients where you require oxygen therapies and severe respiratory distresses, sepsis, where I already told you, where you require oxygen immediately, otherwise anaerobic metabolism. Hypothermia in heat stroke is always going to mimic your respiratory tract problem. So you have to rule out hypothermia, heat stroke whenever you see respiratory. This is a post-stress disease because the lung cannot expand, so you require oxygen therapy. Congestive heart failure, where you have wet lung, anemia, shock, pulmonary contusions, seizures. These conditions you will have to take. So you should know something about oxygen cylinders. We have A, B. Previously we had nomenclature. So now, first thing you should know is it's not a very expensive thing to have an oxygen at your clinic. Our cylinder will cost you, which you can use for about 2 hours of oxygen therapy without any problem. Cost you with initial investment will cost you somewhere 4,000 to 5,000 rupees, along with the stand, pressure gauge, and opening devices. All these things will cost you somewhere around 4,000 to 5,000 rupees. Subsequently, only cylinder exchange will cost you hardly 300 rupees. So you have the old one is A, B, C, D, and all the old nomenclature of cylinders. The new nomenclature, you have different names. This is for you to understand. I'm not asking you to learn from this picture. I just want you to learn what are the newer things. When you are buying an oxygen cylinder, you should know these basic things. The new nomenclature now, what capacity as oxygen cylinder you have to buy. All these things are meant by these things. Okay, so this is the thing, the total quantity of the oxygen available to you in each of the cylinders. So for when you buy, you should see this thing and then purchase accordingly according to your need. So this is a rough, formula to calculate how much time your tank will last. Because supposing you are doing a surgery, you have been using the cylinder quite often, and suddenly one day you have a surgery and you want to know how long it will last. Then this is a small formula to calculate how much of oxygen is left in the tank. And you have lot of this sort of apps, mobile apps are there. You'll have to download them for your calculation. So this is just for you to know. I'm not asking you to go through this immediately, but when you buy an oxygen cylinder for your use, you have to download these things so that in future, when you want to know how much of balance oxygen is there, you will be able to know from using these calculators. Lots of apps are there. You can download anything. So this is one type of calculator where you have to take the pressure gauge, how much pressure is there when you open the cylinder. Then what is the flow rate you want. Usually it is about 5 to 6 liters per minute. That is the flow rate. When you use that, you can calculate and you will get the amount of oxygen left in the tank. So this is a rough calculation where you get when you put a swan as a pressure of 200 and inflow of 4 liters per minute, then you know how much this tank has got. So it lasts for another 70 minutes. So if you can do a surgery within 70 minutes, the tank will support your oxygen treatment. So oxygen generator or a concentrator. This is very helpful for a slightly bigger setup where you have more cases. So it generates oxygen from the atmospheric air. So you don't require to change the cylinder every time, and you don't have to bother about how much of a cylinder is back, and all those things you need not bother. This is definitely a must for a emergency setup. Normally you give 4 to 5 liters of oxygen per minute flow rate. And in case where you have severe distress and flow by or a nasal prongs, you can go up to 6 to 8 liters per minute. And you should also know how long you can keep oxygen. If you are giving at 4 to 5 liters per minute, it should not go for more than 12 to 14 hours because it can cause severe injury to the alveoli. So these are the different methods. So you have a hood method. This is a pediatric hood which you get as a plastic tray with a small hole, and you can have 2 holes in the side where you can put oxygen also. Swan, and you just allow the head alone to be inside that hood, and you can deliver oxygen into the hoods. And next is a mask method. A very conscious pet will not accept this mask method. Only a pet which is not conscious will probably accept this mask method. So nasal prongs are very good. So nasal prongs also, you should be able to suture this nasal prongs to the nasal cavity, above the nasal cavity, so that it is useful to give oxygen for a longer duration of time. Not only for that purpose, supposing you are intubating a pug with a brachycephalic syndrome. So once you have given enough oxygen and enough time has elapsed, you have sedated and things like that. When you want to remove the intubation, when you want to remove the swan, then again there will be a severe block. At that time, this sort of nasal prongs will help you in maintaining the oxygen for some more time. Okay, flow by oxygen is useful for most of the practical respiratory tract diseases, both lower respiratory tract diseases or bronchoalveolar diseases or tracheal diseases. To start with, you can give flow by oxygen, which will be more than sufficient. 60% of the inspired air will contain oxygen, and therefore that will be sufficient to give oxygen therapy for a normal pet. And the e-collar is also an excellent option. Normal e-collar, the lower 2/3 you finish with a cellophane tape, you stick them with a duct tape, and top alone you give some gap about 1/4 of the space, so that the carbon dioxide can go out of the collar. So endotracheal intubation, I told you that you should be able to learn the skill of endotracheal intubation, because this means the life is in your hands. I told you, once you intubate, you can, through this the intubated tube itself, you can put several drugs like naloxone, atropine, Valium, lignocaine, all those things you can put through this vein. Supposing you have severe bradycardia, you can put adrenaline, you can put in the tube. Supposing you have severe tachycardia, you can put lignocaine. Supposing you don't have absolutely you don't have respiration, you can put naloxone or doxapram. All these things are immediate 1 second procedure to save an animal once you intubate them. So use the arytenoid cartilages, vocal folds, and laryngeal inlet as a landmark, and insert the endotracheal tube, and never insert it blindly. You can cause severe inflammation to the all these organs which is surrounding the windpipe. So that will again cause more problems. So you should know how to intubate an animal. So once intubated, the life of the animal is in your hands. I told you about this ampu bag. Ampu bag, through ampu bag, you can deliver oxygen. You can deliver all critical care medicines through this ampu bag. And you can also ventilate with the ampu bag. If you don't have a mechanical ventilator, you can ampu bag, you can ventilate the animal from, respiratory problems. So this is nebulization. So this is a nebulizer machine. So other is a nebulizer. So you can use the respules which are available in human practice, bronchodilators and antibiotics, or Livolin, albuterol, all those things you can mix in this. If nothing is available, just water and saline itself is an excellent nebulizer for most of the diseases. Just give saline and do coupage. Most of the dogs' respiratory tract system will come to normalcy, because it's a defense mechanism. Once you give saline and do coupage, it helps the dog remove the accumulation inside the bronchioles. So nebulizer is an excellent mechanism by which you can alleviate severe respiratory problems. So what are the drugs used in nebulization? You can use water so that it completely coats the alveoli and trachea and all other structures associated with respiration. Saline is useful for breaking debris. Then bronchodilators like albuterol. Then steroids, fluticasone. Then antibiotics. You can use aminoglycosides like gentamicin or amikacin, and mucolytic agents like N-acetylcysteine when there is severe, fibrin formation inside the lungs. So to remove those things, you can use N-acetylcysteine. And then again, a nebulizer can be administered through a face mask, or through a tent, or through an endotracheal tube, or a tracheostomy tube, or you have these puffs which are human beings are using for asthma. Same thing with the attachment for animals is coming in the market. You can use them to give puffs, 6 to 8 puffs every 10 minutes. You can keep so that they become comfortable after giving a puff. So either nebulizer or this puff method can be used in veterinary medicine for the benefit of severely depressed respiratory tract diseases patients. When you come to upper respiratory tract diseases, which we have already seen the previously, you have nasal diseases, you have laryngeal diseases, you have tracheal diseases, which we will see what are the major problems we come across in our practice. So airway problems, you have to relieve the obstruction. So we will see what they are later. So basic treatment protocol, you have to relieve the obstruction. So you have to sedate, intubate, and tracheostomy. All these things are relieving the obstruction. Treat hypothermia. All these patients will be hypothermic. They'll have a very high temperature. So you'll have to actively cool them. You can use alcohol in their, inguinal region. You can apply alcohol into the lateral aspect. You can use a fan to cool them. You can give IV fluids, which is cooled. You can give a rectal cooling, cold water enemas. All these things can treat hypothermia. Always consider heat stroke. So what are the normal obstructive airflow disease you normally see? I already told you last time, nasal aspergillosis is a very common disease you see in certain breeds of dogs with long noses, and brachycephalic airway syndrome you see in dogs with short hair, thing like pugs, bulldogs, French bulldogs, all those breeds, you find this brachycephalic airway syndrome. We will see what is brachycephalic airway syndrome is, which you already discussed. Laryngeal collapse as a consequent to brachycephalic airway syndrome, or as a part of brachycephalic airway syndrome, you have laryngeal collapse. Laryngeal paralysis, as you see brachycephalic airway syndrome in small breeds, laryngeal paralysis you see in large breeds. Especially in India, you get laryngeal paralysis mostly in Labrador retrievers. So tracheal collapse, again you see in small breeds like Shih Tzus, Pomeranians, all these things you see tracheal collapse. So whenever you have a dog less than 10 kilos having severe inspiratory striders, then you should always suspect tracheal collapse. Okay, less important ones are tracheal stenosis, nasopharyngeal polyps, and things like that. Nasopharyngeal polyps are very common in cats. So these are lesser important. Nasal aspergillosis. So you find the typical clinical signs are very purulent and mucopurulent discharge, and you see the ulcerated nasal planum, and you see sneezing. So when you see sneezing, you should also know something about reverse sneezing. Sneezing is outward throw of burst of air. For example, as you can see now, like that is sneezing. Reverse sneezing is exactly opposite direction. You have inhaled this one through the same cavity. That is reverse sneezing. You should usually find in foreign bodies in the hot palate or soft palate or mites. Such are those conditions you see reverse sneezing. Reverse sneezing sometimes is very difficult to diagnose. Epistaxis also you get in nasal aspergillosis. If you have a unilateral epistaxis, it is always before the palate. If you have bilateral, if it is after the palate. So if it is unilateral epistaxis, always suspect nasal aspergillosis, and you always have open mouth breathing because this is going to be blocking. So the treatment for nasal aspergillosis is topical antifungal, less responding to this topical antifungal. You can give ketoconazole or itraconazole or tribenifine, all those drugs for topical treatment, but you have very less response to that. Systemic antifungals, again, the response is not so. For a chronic aspergillosis, systemic antifungal, because this fungal aspergillosis, hyphae and organisms are there in the turbinates. So they are not reachable by even systemic antifungals. So they are less responsive for even systemic antifungals. Nevertheless, whenever we can't do anything about the surgical procedure, then we'll have to go in for systemic antifungals. Then invasive surgical procedures, we've got two methods. One is called soak method. The soak method is, I've already told you last time itself, you'll have to put a Foley's catheter in the nasal cavity, and the oronasal cavity also should be plugged by Foley's catheter, and you introduce itraconazole into the cavity, nasal cavity, and soak it for 1 hour. This is weekly once procedure done for up to the disease becoming all right. Next is trephining. You trephine the skull and make hole and put a tube inside. And then this is a IP procedure. You have to admit the patient in IP. You have to sedate them, and you have to put holes on the turbinates, and then you'll have to fix the tubes, and then you'll have to regularly morning and evening inject itraconazole into the nasal cavity, nasal turbinates. So the medical treatment is amphotericin B. So I just giving you some dose, how to give all those things. Fluconazole, and what are the dose and how frequently you have to give. Itraconazole, terbinafine, hydroconazole. All these drugs can be given parenterally. The first amphotericin is given intravenously, and other all azole group of drugs can be given orally, and you can try and see if it is responding to treatment in the absence of doing a procedure. So this is a soak procedure. The animal is put on ventral recumbency, sedated and intubated, and both the nasal cavity and the oronasal cavity is plugged with a Foley's catheter after filling in the nasal cavity with itraconazole. And the animal should be on sedation, gas anesthesia for 1 hour. Weekly once it is done. The trephining, you can see the two tubes inserted into the skull from the top. So they will be like that in the inpatient ward, and every day the itraconazole will be poured into that, and you have to plug the again here also the nasal cavity through the Foley's catheter, so otherwise it will run away. So this is a trephining method. Brachycephalic syndrome usually seen in breeds like pugs, French bulldogs, Rottweilers, where they have a short snout and an elongated skull. Okay, so when these breeds have been evolved, they have not compensated the growth inside. So they'll have a longer soft palate. So that soft palate will come in the way of the respiration, and they'll stop the air from entering into the pharynx. So that can cause a problem. Stenotic gnats themselves also can stop the inspired air. And the dog makes severe efforts when the pharynx is closed and the epiglottis is closed. It makes severe efforts, inspiratory efforts, and these severe inspiratory efforts make negative pressure, and the laryngeal sacs are sucked into the cavity, and they completely block the swan airway. And this time it becomes very serious, and there's a total block of air going into the pharynx and the larynx. And with the result, the animal will be presented to you sometimes with severe cyanosis. So this is a time where we'll have to act very fast, intubate them or do a tracheostomy and give oxygen and save the animal from catastrophic events. And subsequently, you will have to plan what surgery we can do in these sort of breeds. So sometimes you have stenotic gnats in some dogs. Sometimes you have stenotic gnats and elongated soft palate. Sometimes you have tracheal hypoplasia. Sometimes you have laryngeal sacral aversion. See, either combination of these things can happen in the dog which is presented to you. Not necessarily the dog should be there in the same dog which is presented to you. Based on what is there, you'll have to plan your surgical procedure. This is the it has a severe closed glottis. Sometimes the dog will be presented in still very embarrassing position. See, that makes like inspiratory striders like that. Sometimes such of those cases have severe respiratory embarrassment. So it will be either having a milder form. See, when the pet is brought to you for the first time, and as you see in the video, if it is in the minimal stage, you can always explain to the owner what the problem in future can be, and you can plan the surgery well in ahead instead of waiting for a catastrophic event to happen. So the immediate medical management of this brachycephalic syndrome, the once the dog comes, we should be able to give oxygen therapy. But you know that the oral cavity is completely blocked. It has got probably a NAS which is closed, or it has got an elongated soft palate which is closed. Already it has been having a problem, so it's all inflamed and closing completely. Even if you give oxygen, it cannot enter into the trachea. So either we have to do a tracheostomy, or at least we have to do intubate the animal and give oxygen therapy for a dog which is presented to you in a very, very bad state with cyanosis and severe respiratory embarrassment, both with severe respiratory striders. And butyrophenol 0.2 to 0.4 milligram per kg body weight should be given as an analgesic and as a sedative, so that these dogs are not making more efforts in the inspiration and respiration and make things worse. And cough suppressants like hydrocodone, codeine sulfate, all this thing can be tried. Anxiolytic drugs can be tried subsequently. As a immediate management is oxygen therapy. Once they settle down, they become better. The inflammation comes down after using anti-inflammatories, butyrophenol and things like that. Then you can use anxiolytic drugs for management. And the surgical management of brachycephalic syndrome or nasal wedge reaction, where you make a small wedge and make it wider so that it can respiration can be better. Staphylectomy is removal of the front portion of the soft palate, which is covering the glottis. That can be trimmed and sutured. This is also a very simple technique which we regularly do at Chennai. So staphylectomy can done. Laryngeal sacculectomy also, you can use a long scissors and clip them. Laryngeals, both the laryngeals can be, saccules can be clipped so that it doesn't get sucked in and block the ways. So this is a surgical correction of the soft palate.